Both of them do a large amount of complex interventions and even TAVIs and all other procedures. But today we are going to restrict our discussion to complex PCI, which includes CTO. They have just finished their talks in Hall B, and we would like to get to know more about their actual practice in this field in United States. Welcome, gentlemen.
Thank you. Thank you.
My pleasure to have you here. Let me start with Dr. Daggubati. Complex PCI, what do you mean by complex PCI? What is your definition of a complex PCI?
You know, that's a very tricky question, because complex PCI for someone may not mean complex for a different person. So in my own terminology, I think complex PCI is someone who has a heavy calcified coronary artery lesion that does not dilate well with just a regular pre-dilatation balloon. And some people include under complex PCI left main, any bifurcation lesion, or a chronic total occlusion. All of these are considered as complex PCI.
Exactly. There doesn't seem to be one uniform definition. So how would you look at what is complex PCI for you?
So when I look at complex PCI, I look at two things. As I said in my talk, there is the complex anatomy and there is the complex patient. Complex anatomy is a lot of the things that Ramesh mentioned: left main, highly calcified lesions, long bifurcation lesions, tortuosity, all those things that make a procedure technically challenging. But clinically, there are complex patients. There are patients with low ejection fraction, patients with bad renal function, patients who have multiple medical comorbidities where the safety margin for error is very, very narrow. So to me, the combination of the two is what makes a procedure complex. It's both anatomy and patient characteristics.
Absolutely. I fully agree with that. Now, having said this as a definition, I know that any cardiologist can do any interventional procedure today. Things have become much easier with the number of available equipment and setups. But what would be the prerequisite for somebody to attempt a very complex PCI?
To me, there are two things. One, as you said, experience is the most important thing. That is critical. And that means being facile with multiple techniques and equipment. That is critical. Whether it be atherectomy, whatever be the choice of atherectomy, laser, rotational, or the newer one, shockwave, whatever it may be, that's fine. The facility with support devices, balloon pumps, impalas, whatever is available. But most importantly, looking at the whole picture and planning ahead, to me, is the most important thing. So I don't think there's anything that cannot be done by a well-trained interventional cardiologist, as long as they have the requisite equipment and the training for it.
Agreed, yeah. Well, good training, expertise, good facilities in your center,
Absolutely.
Availability of all the devices that are available to do this procedure, as you rightly said. Now, let's take up some of the issues of this complex PCI. Let's take up, you have done an angiogram and you see some calcification. I would love to know, how do you assess that calcification? Can I do a balloon angioplasty on this, or do I need a rota on this, or what sort of anti-calcific treatment? How do you make that judgment on an angiogram? Because that's the first line of your investigations.
Yeah. I mean, angiogram is still gold standard for us to do any procedure as a prerequisite, but angiogram itself may not be able to assess the degree of calcification in that coronary artery. If you do see railroad tracks of calcium on either side of the vessel, that is considered as severe calcification. But absence of that, railroad calcification on either side of the vessel, does not mean that calcium is not there in that vessel. So you have to probably depend on some sort of imaging, whether intravascular ultrasound or optical coherence tomography, to accurately assess the calcification. And so I think, as we were saying earlier, in our training program, we classify lesions, complex lesions, as type A, B, C, and C being the worst of the worst, heavily calcified, long, tortuous, chronic total occlusion lesions. Why do we need to know also is very important, Dr. Khane. The incidence of peri-procedural MI or complications from this procedure is much higher in a complex PCI as compared to a type A lesion. So both of us, we know, we in our programs, so when we trained, we were only given a type A lesion in the beginning. The first 100 procedures might be type A, then we go on to type B, then we go on to type C. So training is very imminent to be able to do this complex PCI, whether including atherectomy or not. So I would actually put a balloon first, even in the calcified lesion based on an angiogram. If you do not have the facilities of IVUS or OCT, small balloon, a 2O balloon, if it doesn't predilate, then that is going to be a rock of calcium there. That's a simple balloon test that can detect the calcium.
Yeah, in fact, we call that as a poor man's IVUS. You know, we actually put an NC balloon, which is of the similar diameter to the artery, and just do at a nominal pressure. Do you do that in US, or you all go for straight away for IVUS?
No, I think absolutely. I'd say 95% of operators would still use that as a marker. Angiographically, sometimes you're 100% sure that you have calcium that is going to be undilatable. In those cases, it's fairly common to start with an atherectomy strategy. But in those cases where either you are unsure or you don't think you can even get an IVUS catheter through, this is exactly the practice in most places, to take a smaller balloon and dilate it, and if it's undilatable, then plan the next step.
Yeah, in fact, you need to stop before you get an extensive
That's correct.
dissection, so that the other procedures don't become dangerous after that. So avoid a dissection and then plan what next. Now the problem, what I will tell you, what we face is, a lot of us are trained in doing rota and other atherectomy procedures, but many of the people get they don't like. They usually like to do balloon angioplasty because that's the commonest thing, and they get away, and that's the run of the mill, and your bread and butter comes through a balloon angioplasty with a stent. So short of rota, what are the other things that are available to treat a calcific lesion today?
So I think obviously the cutting balloon and the scoring balloons, both are available. They often allow you to expand your lesion. Now, we have to remember, I think it's critically important as we start to deal with more complex lesions. Just because you do a complex lesion doesn't allow you to get away with a shoddy result. You still have to get a well-expanded stent. You have to make sure the minimal luminal area is good enough that you're not going to get stent thrombosis, apposition is good. All of those things are critically important. So lesion preparation is extremely important. Whether you use a scoring balloon, a cutting balloon, or go beyond that to any of the atherectomy devices, that is a choice that the lesion will dictate, but there is not any room for laziness in doing that.
Absolutely, yeah. You need to get that stent well expanded.
That's
so
correct.
The preparation is the key.
Is the key.
You just should never put a stent unless you have prepared the lesion well. That's the concept, because many times if you put a stent beforehand, before you go an undersized balloon and then put a stent,
Yes.
you'll end up unexpanded stent, and then whatever you do doesn't seem to work there. Then you'll end up in a big problem.
I mean, we also have OPN balloons now. I think they are available in India more than actually in the United States.
So
These
can you
are-
tell us a little bit about this OPN balloon? You have, I know it's not available in US, but
Yes.
we have it here, just available few
I
months
had
back.
the
Yeah.
opportunity to use it
Oh, great.
OUS.
So what is this OPN balloon? Many of our audience may not have heard of it because it's just available.
Right, and the OPN balloon is a highly non-compliant balloon. It can go up to even 30 to 40 atmospheres of pressure. It can break large amounts of calcium. Obviously, most of the calcium is within the intima and media, so that calcium can be broken down with this OPN balloon. So these are high-pressure, non-compliant balloons that can take into high pressures. So on top of that, if that does not work, which we are hoping that as clinical trials would prove, the lithoplasty or blood balloons, lithoplasty has been
So
invented
what
by
is this
Todd
lithoplasty? You can tell us something about
So
lithoplasty?
the concept of lithoplasty, actually those devices were first used, still being used in the periphery, is the concept that you can use shockwave, very similar to what you use in lithotripsy to break up kidney stones, for example. Use shock waves to break calcium deposits which are in the intima and the media, allowing you to modify the plaque that way. So initial experience in Europe appears to be very positive so far. Obviously, we have no outcomes data yet, but I certainly anticipate that in the next 2 years, these devices will be available very
Yeah, I think the initial data came with disrupt coronary artery disease 1 trial, and now the second, number 2 is going on in Europe with about 120 patients. So we eagerly await that. I again know that it's not approved in the US, so you can't use it, but the Europeans have started using it. And surprisingly, both this OPN balloon and the lithotripsy balloon, what they have shown is they have not seen extensive dissections or perforation. So far it has not been seen. So I don't know whether that will hold true, but we need to keep our eyes open. but the data at the present moment, you will agree with me, is quite
looks very
favorable.
promising.
And people who want to do only balloon, maybe these are the two options. And of course, I want to know, so how would you choose between a rota or an OSA or orbital atherectomy? How do you choose between the two?
So for me, the algorithm is fairly simple. I save orbital atherectomy for devices where I think rota is likely to be harmful. So very tortuous lesions where I think with the calcium is very, very eccentric, possibly leading my rota to go into the non-calcified segment. So those are the segments that I tend to use orbital atherectomy more often. Osteal lesions, I prefer rotational atherectomy over orbital atherectomy. Though with the orbital atherectomy, you can, as you say, drill backwards. So if you can get across the lesion, you can actually come back with the orbital atherectomy device. But in general, what happens in most practices is people use what they're most comfortable with. And I think that's the key, is that you got to be comfortable with one device as best as you can, and then end up using that more often than not.
To the best of my knowledge, we don't have orbital atherectomy here, but usually one of the relative contraindication is osteal lesions, because you have to start from outside and you don't know what will happen to that.
Or you have to come across the lesion and drill backwards.
Yeah. So what is the size of the rota that you use when you want to do rotational atherectomy? Your choice of size of the burr, or do you step burr, or you want to use only one burr? How do you go? Say vessel is 3.5 and extensive calcification.
That's very good. Contrary to everyone's belief, even in the United States, we are very cost effective.
Absolutely. That's
so we don't use a 1.25, then 1.5, then 1.75 and 2.0 burrs. All the burrs that are available maximum up to 2.25. So I start personally with the 1.5 rotor, and then I'll take a non-compliant balloon, and if I can get good dilatation of the lesion, then I'm done. If not, then I'll go with a 2.0 rotor burr.
So absolutely. That's what we do here also. We use a 1.5 or 50% of the size, and then we may use a cutting balloon or an NC balloon, depending on that, because we have found cutting balloon also helps. And then finally an NC balloon 1:1 before you go with the stent. So the main thing is, please get the vessel prepared well. Yeah, that's the whole concept. Okay, now having said all this, now this is all blind. You have calcification, you are trying to use a balloon, then cutting balloon, then rota. You don't even know whether the calcification is intimal, it is deep, what is the depth of the calcification, what is the length of the calcification. So herein comes to me or my mind the importance of imaging in patients with complex angioplasties, where your result is vital to the survival of that patient. So I believe that imaging is essential in patients with complex angioplasties, and given a choice, if it is cost effective, I would love to use it in every patient. What would you say?
I completely agree, and I also agree that it is significantly underutilized, not just here, but worldwide. I think the data is very clear. The data is also fairly clear that outcomes are better when imaging is an adjunct to PCI. My personal practice is to use IVUS when I'm trying to assess the lesion, and OCT when I'm trying to assess the stent. So generally that's the principle. And to your question, it is not uncommon for me to do a rotational atherectomy run followed by a quick IVUS image to see what kind of result do I have, what kind of vessel lumen size am I looking for. And then after the stent is deployed, not in every case, but many times, if it's a long lesion, use OCT to make sure that the stent is well opposed, well expanded, that there are no edge dissections, etc. So I think I completely agree that you need more imaging, especially the more complex the case. I have a rule in my lab, every left main gets an IVUS. It doesn't matter, how easy or how complex, every left main gets an IVUS. So, I think it behooves all of us to, use a little bit more imaging in our cases.
Yeah, I would agree with you, but I would love to know, like you can't afford to do an IVUS and OCT. Maybe very few centers can have the luxury of doing both, because both have a little bit different utilities in a given patient. But what is your choice? You use OCT more or IVUS more? And I think the data in IVUS is much more extensive as compared to OCT, though the pictures of OCT look gorgeous.
Right. I think that's absolutely. I don't use both of them in the same patient for the same lesion assessment or pre and post. So my choice most of the time nowadays is OCT. Okay. OCT, except probably in osteal left main lesions, you can, or osteal RCA lesions, you can actually do lesion assessment, the length of the stent that you want to choose, and everything has been very well shown in the Illumin 3 study that actually that we can do great job by OCT alone, and pre and post, as well as how is the stent expanded, the rendered stent and the three-dimensional view, and very easy to identify dissections, much higher resolution as compared to IVUS.
Yeah. So what I wanted to ask you was, now we have even 60 megahertz IVUS, and that gives you
Good resolution.
very good quality images, almost similar to OCT. The question that I have for you is, should one be doing an imaging before he puts in the balloon, or should the imaging be done after you put the stent to assess, and what is the importance of doing it?
There are pros and cons of both approaches. I think the importance of pre-imaging becomes more important when you're uncertain whether you want to do plaque modification or how to do plaque modification. In those circumstances, IVUSing or imaging before, I think, is extremely vital in deciding your strategy. In those cases where you've already made a decision to do plaque modification, whatever the strategy may be, I think you need to use IVUS to make sure that you have good results at the end of the case in terms of your stent expansion, apposition, edge dissection, etc. And again, what modality you use is probably not that critical at this point, because there's not much data telling us that one is significantly better than the other. But it is critical that whatever modality you use, you're a real expert in it and you're very comfortable with it.
Absolutely.
So Ramesh, what has happened is that if you read the data, after the data on IVUS has been published, ADAPT-DS, you have the IVL, XPL stand, then you have the latest now all-comers IVUS data. So what they have found is that when you use IVUS, obviously the results are better, and they have mortality benefit, MI benefit, restenosis benefit, but they have landed up using bigger stents, longer stents, and higher pressures. So how do you put it? So when we don't use that, we don't use all this.
No, that's a fantastic question. Actually, somebody recently asked me the same thing. Aren't we doing injustice by using longer stents? So that was the old dictum that we have said, it is better to put short stents,
yes.
less restenosis. But in fact, what the ultimate study recently has shown in 1,400 patients, as you mentioned, the TLR and MI rates have been halved by using intravascular ultrasound from 8 centers in China as compared to angiography alone. And I also say that probably when you're using this catheter, it is better to use the IVUS or OCT for both pre and post. And even if you use a longer stent, it is better to stent the area from normal vessel to normal vessel, so that you don't land in a plaque causing dissections or distal embolization and more problems. So I think long stent is okay as long as you put it in from a normal vessel to normal vessel that is shown by intravascular imaging.
Yeah. Now with this data, if you really see, even in US, I know that the penetration of imaging is almost 80% in Japan, but there are reasons for it because they get reimbursement. In US, to the best of my knowledge, it's only about 15%, whereas in Europe it is less than 10%. So in India, less than 10%. So if we have so much of advantages, do you think in the near future this is going to change?
I think so. I think as data are emerging that outcomes are impacted with imaging, you will see this more and more as part of our guidelines, wherein we're being sort of directed or being advised that you're better off using imaging. Guidelines have a very strong way of influencing our practice decisions, especially in the United States. And I think with the emerging data, till this point, till about a year and a half ago, we really could not make a very strong argument for using imaging as it was linked to outcomes. We had intermediate outcomes like MLAs and stent expansion, etc., but not hard outcomes. But now that we have some hard outcomes, you can certainly see that this is going to be driven to the point where more and more people will be using it.
Okay, now let's come to a different aspect. You have a patient of a complex PCI that you want to do. His ejection fraction is, say, 25%. Now, he's stable. So would you use a support device in this? So when do you really use these support devices, and which one do you choose, and why do you choose that one?
So for me, support devices are not purely it's not a linear decision making. It's not everybody with a 25% EF doesn't need a support device. It depends upon what are you planning to do, how compensated is the patient clinically, what are the other risk factors around that patient that may allow you to do your procedure easily or not. For example, a 25% EF, but an ostial left main stenosis, I don't think requires a support device as long as you're not planning to do a big, long, complex atherectomy on that patient. If it's a simple in and out stent, that's exactly what it is. On the other hand, a EF of 25% of the distal left main bifurcation that's calcified, requiring a 2-stent strategy and rotational atherectomy, is a completely different animal. In that case, I would prefer to have support. And my personal preference in these cases is to actually use an Impella device, because while the balloon pump has a lot of experience, I don't believe it has a lot of data supporting it. So therefore, my current practice for all of my high-risk PCIs is to use an Impella device, depending upon the patient's anatomy, depending upon the iliac size, either a 2.5 device or an Impella CP device. That is usually my practice.
Okay, the Impella is just come back to our country. You know, we did not have it for a long time. It was there initially, but it's an expensive proposition. The Impella device cost around 14 to 15 lakhs if you want to put it. So does IBP help or doesn't help? What is your opinion?
So I take it a little bit differently. I also use a lot of Impella in the United States, but my decision making is based on their end diastolic pressures. Even if the EF is 25 and they're well compensated, I'm okay with actually doing without any support. But if I do use the support, I base it on a right heart catheterization. If their cardiac index is more than 1.8 and less than 2.2, I still go ahead with a balloon pump. And if it is less than 1.8 up to about 1.5 or so, then I think Impella is good. But if it is severe, meaning if you want to use any device in people who has a cardiac index of 1.1 or lower, and even if they are compensated heart failure patients, I would actually go for a larger device such as Impella 5.0 or a tandem heart in such patients.
I know you do have those extra ECMO and all. So when do you use an ECMO? Have you done cases with ECMO?
We've done cases with ECMO where you need complete support, meaning not only do you need hemodynamic support, but you may need oxygenation as well. With the current technology that's available percutaneously, we very rarely put people on ECMO simply to do a percutaneous intervention. That's pretty rare. We do tend to use those when we have patients in cardiogenic shock where oxygenation is an issue, or in those patients where we have a true bailout strategy, wherein our plan is if the intervention fails, they're going to go and have bypass surgery. In those patients, we will put them on ECMO ahead of time.
One of the new things which we read was presented at American Heart in 2018, just a month back, or this month only if I'm not mistaken, by Naveen Kapoor from Tufts University. He talks about unloading the left ventricle before you do a palming. Yep. So instead of door to balloon time, he talks about door to unloading time. Can you just elaborate on this concept?
So we were part of the door to unloading trial. We enrolled about 6 patients in that study. The door to unloading trial comes from very solid basic science evidence that clearly shows that when you unload the ventricle in conjunction with a PCI or even before a PCI, you can reduce the size of the infarct. So the whole idea behind the door to unloading trial was what was presented at the AHA was a safety and efficacy trial. Because when we, for the longest time, we lived in the world of door to balloon. So even to propose that you're going to do something different from that, you have to show that you're not harming the patient, which is what this trial showed. But in the trial, it also showed, which was an exploratory endpoint, was outcomes related to those patients with the largest infarcts based upon ST segment elevation sum scores, that those patients seem to have a lower infarct size by MRI when you looked at when they got unloaded before time. So the idea is that if you can unload the ventricle by using an Impella device, because that already shifts your pressure volume loop to the left, reduces your myocardial oxygen consumption, even in the setting of an occluded vessel. In fact, going back to the mid-1980s, there is data from Japanese groups that showed that if you occlude a vessel and you unload the ventricle, your infarct size is smaller than just occluding the vessel and reopening it. So there is some benefit to it on the basic science data, but hopefully the pivotal trial that's coming behind the DTU will address the end.
In fact, one of the interesting that I found when I read that paper was when they waited for 30 minutes after unloading and then did the angioplasty, those results were better than doing an angioplasty immediately after unloading. So, and the concept is to prevent reperfusion injury, because if you immediately open it up, the reperfusion injury is higher. So we have, I think, discussed a lot about this. So now let's move on to a different talk based on his talk, is that chronic total occlusions. We'll just cover up a little bit. So I just want to know from you, because you gave a talk to the sort of a fellows, or it was a tips and tricks. So how do you do an angiographic assessment of a CTO?
Yeah. So I think number one, when you see a chronic total occlusion, don't try to do ad hoc PCI. You need to actually step back, maybe finish the angiogram, and advance another catheter through a femoral or transradial route, and do a dual injection to accurately assess the angiogram, or the chronic total occlusion on the angiogram. So then you come out of the room, you actually probably take off your lead, sit down, look at the angiogram, study it very well, very closely, and maybe take a help from other partners of yours. So we always recommend at least 2 people should look at the angiogram and discuss what is the best approach for that particular patient. So I always say dual injection is almost 100% has to be done, and take your time in assessing the lesion.
Yeah, I fully agree with that. In fact, we have learned, most of us, I would say, have learned CTOs from the Japanese, and I have a few close friends who are big operators in Japan, and he keeps telling me, you have to see that angio for at least half an hour. See your plan A, then go for plan B. What will happen? You have to have a mental image of that CTO segment, so that you can plan where your wire has gone as and when you start the thing. Most of us do mostly antegrade, because by and large nowadays, with the technology that is available, retrograde incidence is going down. Of course, it is important in some. Now, I just want to ask you a hypothetical situation. You see a microchannel, so you try to go with it. But it has been shown that even if you don't see a microchannel, usually there is one. So you can always try and antegrade thinking that there is a microchannel.
Yes.
Do you believe in this concept?
Yes. I mean, antegrade dissection or antegrade wire escalation, and trying to be in the true lumen itself is successful in about 2/3 of the patients. And that's why probably not every patient has to have a retrograde option, or has to have antegrade dissection re-entry. So you can probably be successful in a CT or PCI just by staying in the true lumen, true to true lumen itself.
Okay, now having started antegrade, your wire distinctly goes into a false lumen. So how do you do a parallel wire? You just go with another wire, or would you like to use a dual lumen catheter? Do you think that helps?
Yes.
Or
So
how do you proceed?
Yes, I think in Japan they have shown IVUS guided re-entry, putting that wire in the subintimal space and using IVUS guided re-entry with the second wire has been helpful. If not, I actually choose a second wire, parallel wire technique, trying to get into the true lumen with a different wire, which is usually Gaia first, that I'll start off with.
Okay, yeah. So because there are different wires available, so how would you say one should get acquainted with all the different wires of different companies, or what is your philosophy?
I think if you go to my CTO card, it is technically impossible to get acquainted with every one of those wires.
Absolutely.
So I think every CTO operator needs to have a tool house of the wires that they're most comfortable with. But that means you need a broad spectrum of wires, from things that you can use to go subintimal to things that you can use to stay interluminal. Get used to it, get comfortable, because it's not just the wire, but the feel of the wire, and you have to get used to it so that you can be safe. So certainly, I don't think it's feasible to know each and every wire in this day and age. So you have to find your toolkit and work with it.
So most of us learn from the Japanese, so we are very comfortable with the Asahi wires. We have not seen the other wires at all, and they have everything under the sun. So you get used to one set of wires, and you require 3 or 4 wires. You require a wire which can take you through a soft plaque. You can have a wire with like Conquest Pro, which will take you through a hard thing. And you require in between an intermediate thing, which will give you, of course, knowledge of more wires is important. Now, having said that, in US nowadays you have this cross-boss and Stingray technology. So when is that ideally to be done? What are the prerequisites for doing a cross-boss Stingray type of a ADR?
Right. As you said earlier, when you don't see any microchannels, and if you have a antegrade dissection re-entry option, which is with a blunt stump, you can actually loop the wire and push it down, or go with the cross-boss and go subintimal space, come out and finally find a area where you can re-enter in the distal vessel and use a stingray balloon to which has almost like a double lumen, and you can then pass a stiff wire which could be a Pilot 200 or the stingray wire itself comes in, and you can use that to re-enter the distal lumen, and then you'll be stenting from a true lumen and through a dissection plane back into the true lumen.
So this is my personal, I wanted to ask always people like Kalan Sundaram, we work sometimes together. So when you do this, you'll end up having a long area of subintimal stenting, whereas the Japanese technology, what they try to do is, at least what they're teaching is to try to restrict that CTO zone to a minimum length. So they try to go retrograde rather than going extensively. So you have, you follow which philosophy, or you have a compromise between the two?
No, actually, yeah, we switch back and forth very quickly. The whole idea is to shorten the time of CT or PCI. So as I mentioned in my talk, there is no strict antegrade or retrograde. You should get rid of that idea. Well, the whole idea is to open up the vessel, whether antegrade, if it doesn't work for 5-10 minutes, switch to retrograde and then come back to antegrade if that doesn't work in another 5-10 minutes. So minimum amount of contrast, minimum amount of radiation, and high success rates can be achieved by following this specific algorithm that has been well written and published by Brilakis. And so we have now data even to say that even though you stent through the dissection, many of these patients never lost their side branches. They don't have worse outcomes than actually a retrograde mechanism. So the whole idea is to get the vessel opened up.
Yeah. So is it a prerequisite that generally this is done when you have a blunt stump, you have a long segment to cross, but your distal vessel should be of good size and well seen so that you can make a good entry into this. So these are the three probably other prerequisites for that. So when would you think that no, this is a patient where I will directly go for retrograde? Is there any chance like that? Is there any cases
obviously,
like that?
when you study the angiogram, if you see a beautiful large channel retrograde and filling up the whole vessel, I think the choice actually should be starting off with the retrograde in that particular patient. And you can see that there may be a hard, heavily calcified stump which is short, but the retrograde channel is good. It is better to do it because antegrade, the calcium cap is much more, proximal cap is always harder than actually going through a retrograde and a distal cap. So I think that success rate is much higher with retrograde, and you should stick to that.
Absolutely, I fully agree with that. So, of course, we can go on and on and on, but I would like to conclude this session now. And gentlemen, thank you very much for conversing with me. And what I can say as a concluding part is that it is possible to do almost every angioplasty and open up any vessel under the sun that is given to us. But if that has to be done, the cardiologist who wants to do it should get himself trained properly, have himself equipped properly so that you have all the equipment to do the case as well as deal with any complications that might arise, have imaging and other facilities available to you, and have all the armamentarium, because as they say that people who have everything are the people who are likely to succeed. Otherwise you may succeed sometime, but at some other time you may fail miserably, and that will be a big setback. Thank you very much, gentlemen, for your...
Thank you for having us.
Much. Thank you.
One more time. Atherosclerotic cardiovascular disease. Good evening. Atherosclerotic cardiovascular disease is one of the major problems in developing and developed countries. Of course, hypertension and hypercholesterolemia are two important causes for the development of ASCVD. Of course, basically one has to change the lifestyle modification, including the healthy diet, exercise, less stress, smoking cessation are all parts of the treatment. When you come to the drugs, statin is a good drug, proven effective in hypercholesterolemia. We come across certain situations where the patient's hypercholesterolemia cannot be controlled only with statin, especially in very high risk groups. So what do the guidelines say? In a very high risk groups, when statin is not effective, we add the second drug called SMB. This SMB prevents cholesterol absorption. It is a very good drug added to statin. Suppose the atorvastatin 10 milligram plus SMB 10 milligram, the effect is like 80 milligram of atorvastatin. So it's a good add-on drug, and SMB especially after the IMPROVE-IT trial, people started using it. It has come back. In the recent ACC guidelines 2018 November, they say very high risk group, the first drug is statin, the second drug is SMB, and third drug is PCSK9 inhibitors. The PCSK9 inhibitors are very good drug, and it can reduce cholesterol up to 50 to 60%. And there are other drugs which can also be used in case of statin myopathy, statin intolerance. As I said, if the statin is not effective, and it can be used in familial hypercholesterolemia. So I will come by one. First is SMB. I told you SMB is a very good drug, and it can be given in the very high risk group. Even in the high risk group, it is a second drug. The PCSK9 inhibitor in the familial hypercholesterolemia and in the very high risk group, it can be used, and when you don't achieve the target LDL 70, there also PCSK9 is useful. Coming to other drugs, the bile acid sequestrants, BAS. There are three drugs: colesilvum, cholestyramine, and cholesterol. The colesilvum is a good drug. Of course, it is not available in India. It is indicated in pregnancy class B indication, and it is also an adjuvant for diabetes. Coming to bile acid coming to the fenofibrate and FAD, these drugs in the subgroups, they have analyzed the meta-analysis of field trial, ACCORD trial, they come out to the conclusion when a patient has got more than 204 triglycerides and less than 34 HDL, these FADs have some benefits. Fish oil, recently in the 2018 New England Journal of Medicine, November 11, they have come out with a reduce it trial, which says the sudden cardiac death, cardiac events are reduced when you take EPA 2 grams twice daily. And there are other new drugs like mipomycin, lametabide, phytol, plant sterols, and niacin. Of course, niacin is an old drug which is now banned because of side effects. After the HPS trial, the drugs are banned and it is not very useful. So the standard of drugs, of course, statin, then comes the SMB, then comes BAS, and in certain hypertriglyceremias, FAS can be, fenofibrate can be tried, and of course fish oil also, the recent evidence is there. But overall, for any healthy life, as I first said, consider first lifestyle modification, healthy diet, good exercise. Then comes the drugs. Before you give the drugs, discuss about the benefit, cost, and of course risk ratios. In any patient, even though you achieve the cholesterol to the target level, even then they get problems, and this is what is called as residual risk. So considering all that, we can give drugs according to the patient individual priority, because if they have some other complication and if they have myopathy, we will have to switch on to different drugs. My message to the patients always is follow good lifestyle, take the drugs regularly, especially when you take statin, you have to continue till lifelong. In case of diabetes, we have diabetic dyslipidemia. Apart from all these drugs, controlling diabetes is the key, and when the patient has got hypertension, controlling hypertension is a very important thing to reduce ASCVD. Thank you for your patient hearing.
Hello? Hello? Yes? Okay. The main problem with the most of the cardiology patients are the patients of stable coronary artery disease. And these patients have exertional angina for a couple of months, maybe years, and they are on various drugs. So there are debates whether which drug is useful, which is not, and what is the role of angiography and angioplasty later on. The main concern is the use of drugs and how long it has to be used. All these patients most of them are young, less than 50 years of age, and initially they are on nitrates, whether you start with a short-acting nitrates or long-acting nitrates. The short-acting nitrates we usually give in acute episodes, but patients who are stable who has a stable coronary artery disease have mostly on the long-acting nitrates. The only problem with the nitrates is, the drug resistance and headache. So we can add, along with the nitrates, we can add the beta blockers, preferably a metoprolol. But unlike metoprolol, there are others, second line of drugs like ivabradine, ranolazine, and trimetazidine. And once these drugs does not work, then all these patients should be thoroughly investigated and sent for some further stress thallium or invasive measurements like coronary angiography, and to look for severity of the coronary artery disease. So, and then comes the role of statin, especially the high dose of statins, either rosuvastatin or atorvastatin, and then the role of antiplatelet in such situation. The initial we used to give clopidogrel 75 milligram once a day, but then newer generations antiplatelets like prasugrelol and ticagrelol, they are all also being used. So antiplatelets have a very useful role in prevention of plaque rupture, and it helps in improving the plaque stabilizations and reduction in the endothelial dysfunctions. Thank you so much.
तो इंटरव्यू
तो भाषण दे दिया,
मेरा इंटरव्यू हो गया।
बहुत भाषण वाला।
Okay, good afternoon. I am Dr. Samin Sharma from CSITV in Mumbai in the CSI conference. I am a director of interventional cardiology at Mount Sinai Medical Center. And on my right side is Dr. Ashok Seth, who is the chairman and most expert interventionist of India. And on my left side is Dr. Upendra Kaul, who is now the director of cardiovascular center science at Batra Hospital. The purpose today is talk about the Indian stents, and I'm so privileged to share this dais with these two expert Indian interventionalists, and will give you some glimpses of what is going on at present, where the Indian stents stand in many of the trials. So one of them, I would start with the talent trial, because the trial which really made a big headline. So Ashok, you were there at TCT in San Diego, and the talent trial was presented, and it actually, for our Indians, you know, I am actually in America for 30 plus years, but I always, anything comes out from India really boosts my further enthusiasm and blood and the confidence. So lot of, there was big noise about the talent trial, and it was subsequently also covered by a lot of media. Can you just tell all our viewers here what it was all about and what was special about this particular stent, which I know was targeted against our most popular stent in the USA?
So you're right, Samin. I think it was a great day for India. There's no question. It was a pride to see the amount of exposure, the amount of publicity which and the amount of attention which India got from this important study. And it's rare when a large pivotal study gets presented on the main forum, on the late-breaking trials at the biggest meeting in the world, and a very scientifically done study. So it made us proud. It not just made us proud because the stent is very good, and that it lived up to the expectations of being a very good stent against a very powerful comparator. The comparator is considered the gold standard of stents at the moment. And our Indian stent, Supraflex, was randomized in a very prospective manner, in a very scientifically designed study, a multi-center prospective study done between Europe and England, and what it showed was non-inferiority. In fact, it showed that it was as good as the best in class of the drug-eluting stents which we've been using of the West for years. So that was one. The fact that it was a great study was the other one, and it made us proud to have such a stent. The fascinating aspect of the stent, by the way, I would still say that this was actually a second generation or a first generation stent of the company, and that also matched up to the best in class stent. Now we can imagine that at the moment we're using the next gen of that company, and it can only be performing better than the second gen stent that we actually use. So it was quite
remarkable.
Quite remarkable.
So Dr. Upendra Kaul, I'm sure you used all the stents, Supraflex, and so tell us, we'll come back to the trial once a little later, your personal experience. And many others, Promus, Synergy, and so how did you, before the trial came, the results came, what was your mindset and what is your feeling that how good the stent was it faring as good as, of course there was not a label that was Americanly tested, tested in a randomized trial, but how was your feeling over the years on that stent?
Well, Supraflex has been one of the very good stents for many years. It first came into the market 7 years ago, and the beauty of the stent, it is ultra thin stent. You know, this is the time when we're talking of ultra thin stents. It's 60 microns. It is chromium cobalt. It has a biodegradable polymer, and it's crossing profile is just 0.039. Xience, the latest stent, the Xience Sierra now has matched its crossing profile of 0.039. And other thing is that the strut thickness of 60 microns is uniform. Small vessels, large vessels, up to 4 millimeter. The other small, this ultra thin stent is, as you know, Orsiro, which again is a very well acclaimed stent. It has gone through many studies like bioflow studies, has shown lower MIs because of low strut thickness. But between 3, 3.5 and 4, it becomes 80 millimicron. So that is the beauty of this stent. So we thought that having got a very good share in India, 11,000 to 12,000 supraflex stents are used in India every month. And Xience about 12,000. So it's very close. Other stents are other Indian stents like CSICON and Merrill stent. So we thought that we need to have a randomized study because we have a registry of supraflex with OCT and everything else in 250 patients showing a very good nominal late loss and a good healing pattern. So we thought that it needs to be done in a prospective multicentric studies, and the most powerful part of the study was that it was all comers, acute MI, grafts, left mains, no exclusion criteria. So this was done in 1400 patients, and as you know, as Ashok said, it came out to be as equivalent with a 4% margin of non-inferiority. It came as equivalent with the stent thrombosis of 0.5 or 0.6% in both. The device-oriented composite endpoints, which is the standard these days, was equivalent. So it fared so well that we have decided now to go in for a superiority study, which is the real thing. And we have also decided to go in diabetics because if you know, the Freedom study against CABG was done with the first generation stents. It was Taxus and Cypher. Stents are not available and we know the limitations of that. So that message that in all settings, in diabetics, surgery is better, this again has to be shown in a prospective study and we're planning that also.
What is interesting about this is that the first in-human study was actually done with a stent called Supracore by myself, the first in-human study of 250 patients. Even at that time, and this is we're talking about now 10 years ago, 11 years ago, the results were amazing. For the first time I saw an Indian stent behaving dramatically, and we at that, again, that study was all comers, it was the first in-human study, and yet we were seeing no restenosis, and for the first time we're seeing long lesions, triple vessel disease, stented with this Supracore and doing very well. So it's extremely promising, but it also suggests one more thing. Two things have come out from this. Firstly, that our devices are good. They just needed to be proven in a scientific manner, and that was very important. And the credibility mattered, not for this country, but it mattered across the world.
Yes.
The second is that this company was able to do an immaculate study against the best comparator. And that again is a first time, I would say, for an Indian stent. If we get more of this, and I believe that, I mean, we can generalize this as Indian stent, but I would say this Indian stent is particularly good. Now, are all Indian stents good? Probably they are, but they need to go through this sort of randomized study to actually, for us to be confident about their use in our patients, and for the world to be confident about the technology that India develops, which is of extremely high standard.
Other thing, Samin, is, as we all know, that the annual attrition rate after 1 year, after angioplasty, whatever stent you use, is 3% per year, which is alarmingly high. So one has to see what can be done to reduce it. One is a very good medical treatment so that the other parts of the vessel remain healthy. But what can be done to the stent? The best thing could be, because whether the stent is a biodegradable polymer stent or a stent with a durable polymer, and the science has shown that good durable polymers are very good and sometimes they may be better because they always are thromboresistant layer there. But one thing is their metal, if it remains in the vessel wall, is going to corrode, is going to leave ions, which can produce subtle, gentle inflammation, which can produce problems later. This was the direction for the BVS. Unfortunately, BVS had a problem. I still feel that that is the way to go about, although, 150, 160 microns is not the way to go. And in that direction also, I think everybody is trying that, although the process has become slow after Abbott, lost its heart with this very thick stents. So, design matters. I think the design of the stent matters, and lower the strut thickness is good, but I don't think strut thickness can go
beyond
less than 30, less than 60, because you need some radial strength, you need some pushability, you need some conformability. So that is the way to go. So I think the $1 million question is going to be, because Xience still has a lot of promise, because we're just showing non-inferiority. So we need to find out whether with a biodegradable polymer, a 60 micron stent will be equivalent to a 60 micron stent with a durable polymer. So both have to be equivalent, because if the thickness matters, then lower is better. So that is the way one possibly should go till the time we get back to metal goes away.
So look, talking about that, it is going to be extremely difficult in the present era for any stent to show superiority. All these stents have become so good. They are getting all thin struts, they are actually getting there, every aspect perfect. Yeah. We are into third generation devices. And I doubt that we'll ever be able to show superiority over one device over the other. And therefore, you're right, the tack has to be totally different. And I do believe bioresorbable scaffolds still hold the biggest promise. Thinner struts and the design characteristics which are being changed are perhaps what we've been looking for, and there's no doubt the older needed to change into new. And that is going to be the future, the disappearing. But another aspect which I actually say is, even this, of non-inferiority of Supraflex over Xience is a huge thing, and I'll tell you why. Yeah. It's huge, not just because it's non-inferior and it's an Indian stent, but cost now matters. So what's the next differentiator for across the world? The next differentiator is, if you've got equivalency, if it's as good, if it delivers well, and if it treats well, then why are we going to pay twice more for a different stent? And that is the things which needed to be proven, and I think that's one of the big steps forward. Yeah. Because if we can't change in the direction of results into superiority, then there is a superiority in it being less expensive. There is a superiority in the way it's been developed and made available. So, and it's a superiority in the way it can be available to the masses in the country. So I think that's the big step forward.
And this gives the confidence to the Indian operators, because many of us rightly had a feeling that the American stents and European stents started long back. This is a new stent. Just being patriotic doesn't make that much of an impact till the time you show that you are bloody very good. You are doing the same thing and cost effective. Although we have a stent price cap there, but Indian stents are able to get into the market with a little more margin than the American stents, and the Xience, Sierra and all that are not going to come. So we need to improve the deliverability of these stents also now. Stent is good, but deliverability has to be improved, and in this trial, talent, because I was the co-chairman, I have the details of the trial. One of the factors was there that the device success was lower, was 97.5 versus close to 99 in that. And one of the reasons was that, because this was a European trial, was that if you're not able to push it, they were going back to their familiar stent. Let us use our familiar stent. So that could also have affected that, because they didn't try to push it harder, because they said, why get into the trouble? We have another stent lying on the shelf. But all said and done, some of the things like shaft crack, kinking and other things have been worked out during the period of the trial also. So the next generation of the Supraflex stent is also focusing on how to make the delivery system slicker. And the newer generation stent, because everybody is getting into everolimus, so is a stent called Tetriflex, which is again 60 microns, but has everolimus as the drug because everolimus is becoming more popular. Although I think sirolimus and everolimus doesn't make a difference. And we have done a 50 patient intravascular, the OCT study, and they've shown that at 3 months and 6 months, the healing is perfect. It is not 0.1, it is about 0.2, 0.3, which is very safe. And all the data analyzed by Alex Abizet in Brazil, and that gives much more and more confidence. So that's what I'm trying to say, that Indian stents have got into the milieu of testing it rigorously and showing it in publications and showing it to the world.
So let's
hope
that this study gives an impetus for firstly more Indian stents, and there are good companies. We know that there are good companies who created good stents in India, other companies. Let's hope that this gives impetus and excitement to others to do such large-scale studies. We understand that it costs money. It's a huge investment, but that huge investment is for India's credibility, growth, research, science, as well as it would be obviously for the sales across the world. And the second aspect is that it gives impetus to the industry in the country itself.
Yeah.
After all, we're talking about made in India. And for us, that made in India is always going to be a pride.
Yeah.
India is one country which has survived on what's come from the West. In a way, yes, they survived because those were the proven stents. They'd done large studies. They had done long-term studies. They had done pivotal studies and had huge data. So there was nothing wrong in that. But now's the time for us to transform that, and that's the made in India spirit. I never want to believe, there's always one thing, okay, made in India cheeze use karo. And I say I never want to believe that what I put into me, I should be able to put into my patients what I would put into me. And unfortunately, unless we make our quality parameters so robust that we can rely, it is studies like this which will make us rely on what is being produced here. Because unfortunately, our quality parameters in this country are still not as uniformly robust as one would have liked to do.
And it's very important to prove or disprove a hypothesis. Like Samin, you may be remembering that Taxus stent was still considered to be a good stent for diabetics, based upon large meta-analysis of Greg Stone, till the time we did the Tuxedo study and showed that everolimus stent was better there, and that was the demise of Taxus. And also in the talent study, the other thing which I will say was a little shortcoming is that diabetics were 21%, because that's the typical European population. We have diabetics as 33, 35%. So we need to also see that it performs equally well in a diabetic patient population. So there are, many things we have got from the talent study, and it has given us the impetus. It's being published in Lancet. That again gives us a credibility that an Indian stent, for the first time, coming into the Lancet as a full paper. So I think the positives are many.
Clearly the excellent study done and by the Indian manufacturers, it's a pride for us, and more importantly that it was proven scientifically better. And since then, further designs even have been made, as Dr. Seth pointed out, that these were the earlier generation, and of course the subsequently will even give rise to a better result. So with that note, we conclude our today's this discussion on the talent study, which used the Supraflex Indian-made sirolimus eluting stent against the top most commonly used stent Xience, and the device-related outcomes were identical, except the crossability procedural success was slightly lower, but that was by using the old generation stent. With that note, I hope you enjoyed this discussion, and wish you a very good evening, and enjoy the CSI conference and try to make a best use of it. Thank you.
Thank you, Samin.
Thank you very much.
You're going to do a voice check now? Or?
Okay.
Voice check? You want to do a voice check now? No. Good afternoon, everyone. Welcome to this session of CSITV. I'm Dr. Karthikeyan. I'm Professor of Cardiology at All India Institute of Medical Sciences. And this is Professor P.P. Mohanan. He's from Westport Hospital in Thrissur. And he's a senior cardiologist who's done a lot of work on ACS in Kerala. So we will be talking to him about the Kerala ACS registry in particular and some other aspects of the ACS scene in India and how we can scale up what they've done in Kerala to the rest of the country. So,
thank you, Professor Karthikeyan, for this opportunity. Kerala ACS registry is the largest ACS registry from India. And as we are aware, despite the grim statistics of cardiovascular disease in our country, we have very poor scientific research output. And that was one of the innovations that the Cardiological Society of India Kerala chapter has done, where we collaborated with about 125 hospitals in Kerala and brought out a registry of 25,753 patients with acute coronary syndrome. And what we saw also surprised us a little bit in the sense that now we have a high STEMI mortality. The STEMI mortality was something to the tune of 8.4%, which is definitely higher than whatever is prevalent in the other part of the country. And this may be attributable to one, of course, the delayed arrival of the patient with ACS, and then the paucity of the reperfusion, the timely reperfusion, and maybe some inappropriate therapy also. And possibly the most important thing was the underusage of guideline-directed medical treatment. So that made us learn quite a number of lessons, how to counter them, and how to sort of get over these inadequacies in the management of acute coronary syndrome.
I wanted to particularly ask you about the one, you mentioned that inappropriate therapies. For example, we have this a bunch of people with ACS, NSTE ACS who received thrombolytic therapy. So why do you think that happened? What was the...
I mean, basically, people have a notion because you should know that out of the 125 hospitals, about 45 to 48% were managed by physicians. I'm not saying that that is the root cause, but people have a notion that, well, whenever you have a thrombotic milieu, antithrombotic drugs or lytic drugs may be useful, but that may be one of the reasons that the physicians are also not really into the guideline-based therapy. So, which we could correct. We could, just like in the West, where they have shown that adherence to the guideline-based therapy through various methods, various trials, they have shown that if you improve by educating the physicians, by educating the paramedics, we can improve the results.
The other interesting thing about the Kerala ACS registry was that your time for STEMI, your time to reperfusion was about 5 hours, was it? So you've also published the access to reperfusion therapies in a separate paper. So I noticed that you said most patients in Kerala live within half an hour of a primary PCI lab. So why do you think there is this discrepancy?
Well, there is one definite reason in the sense. When we did the Kerala ACS registry, that was in 2007, 2009. The number of cath labs at that time was 26, while when we published the access registry in the rural, the setting, the park registry, the primary angioplasty registry, that was in 2016, and when we have 106 cath labs. Okay. So the number of cath labs have significantly improved and possibly that is the one single reason, and of the lessons learned from the Kerala ACS registry also, I am sure, should have kept in their mind, because our rate of reperfusion, the lytic rate was 45% and the primary PCI was a meager 12%, while if you look at the Kerala, the ACS QUIC, the quality improvement data, reperfusion is 60 plus. So there's a tremendous improvement in the reperfusion strategy that is happening.
And what's the primary PCI rate in the quality improvement?
The quality improvement we have touched on to 50%.
That is excellent. So I think the Kerala ACS group needs to be congratulated on what you've done, a pioneering bit of study in this country. I don't think anybody else, any other state, any other CSI, state CSI has managed to do this. So I wanted to ask you, what is it that makes the Kerala group special, so that we can learn from the Kerala group?
We always pride ourselves about the Kerala model. Now you would have heard about the Kerala model of the economic persistence and the surveillance. Same way, I think there is a Kerala model of cardiovascular research where the funding is taken care of by the Cardiological Society. So the investigators need not worry about how do I get the funding for this research. And the second part, there are some devoted groups of people, and mind you, they are not very much trained in any cardiovascular research. Now, I myself is not have like you. I don't have. I didn't undergo any formal training. But then we have been involved in some of these clinical trials and multinational trials, and we wanted to do some legitimate research, because one of the things that we always say is, oh, Indian research is of poor quality. We wanted to have a high quality research with meager reserves. So this, I will say, is a Kerala model where the funding is done by the own institution, your own maybe mother body, fine, if you can do that, fine. Then there are about groups of people, a state coordinator. For example, in Kerala ACS registry and in ACS group, I was fortunate to be the coordinator. Then we have other collaborators. Each one of the cardiologists in Kerala now wanted to be part of the research program, and they have no hesitation to share their data.
So the other interesting thing, I realized that one of the most important things that is needed for doing research is an incentive for doing research. I mean, academic investigators, like in hospitals like ours, we have an academic incentive, so that is a given. But what about, so the large majority of your group are people who do private practice. So what is the incentive? What is it that drives you?
I think once we started the Kerala ACS registry, and that sort of percolated an intense desire among our junior colleagues to be part of some scientific research program. And mind you, we don't pay, we did never pay any of the investigators any substantial sum. Whatever very meager sum that we paid was mainly used to continue the research activity. So I think it is the desire to be part of a research program which will be useful for our patients. And also, that started, now we have 7 registries running in Kerala. A primary PCI registry, a pulmonary hypertension registry, an atrial fibrillation registry, a vitamin K polymorphism registry. You name it, we are running it.
That's amazing. So before we close, I just wanted to get your insights on what do you think are the most important steps you must have seen in the ACS QUIP, which is a follow-up to your ACS registry. What is it that is needed to make at least the state of Kerala comparable to the West, say at least Europe, Western Europe, in terms of access to reperfusion therapies for STEMI? What is it? What are the few things that you think are important?
I mean, very, very important issue that you have brought in, because the systems of care of, especially the STEMI care in our country, is very meager. The systems of care should be there, that's for sure. But then the contribution of a cardiologist is, I will not say is minimal, but is limited. So the second part, that is one part. The second part will be how to improve the adherence to the drugs that he should be getting. Every patient with ACS should be getting a list of drugs. So an admission discharge checklist and audit feedback. Now that is one of our success stories. We gave all these hospitals every monthly an audit feedback report saying that this is the way that I am treating, this is my dual antiplatelet, this is my rate of primary PCI or my reperfusion rate. So, and also the other patient education material, all these matters. the systems of care is something which which definitely
beyond the
merits
scope of. But if I were to ask you only about improving access to reperfusion, you may not comment if you don't want to, but in adjacent Tamil Nadu, there is a push for doing pharmacoinvasive therapy. So what do you think about that? Is that a model which is scalable to the country, or?
Well, I'm not very certain. But if you ask me about Kerala, I mean, Kerala possibly may not be the best state to implement the pharmacoinvasive therapy, because already we have 126, and the areas where fibrinolytic therapy used, I will not say that it is irrelevant, but it is still relevant, but it is it may be relevant in certain situations, certain states where now the cath lab numbers, the sheer presence of a cath lab doesn't warranty the proper reperfusion. We have seen, even despite all these cath labs coming here, your balloon time may be still 4 hours, 3 hours. So what is the fun in that? So I will not say pharmacoinvasive therapy is suitable to every state in Kerala. I mean, every state in India. It may be, it has its relevance. I'm not negating that.
One question about the number of you said more than 100 cath labs in Kerala, small state, so high density of cath labs. So how many of these are private cath labs and how many of them are public cath labs?
I mean, now the government sector has tremendously improved. Earlier it was something like 20-80. Now it's about 35-65 or something. But you again makes another important issues. The mere presence of cath lab doesn't guarantee a 24/7 primary PCI service. Many of them has their limitations.
Plus also reimbursement issues. A lot of it might be out of pocket and patients might not want to.
Absolutely.
Is there also, I know that in some parts of India, patients who are sick, like STEMI patients are often, they are not treated with primary PCI because of the risk of, say, untoward events during the procedure, and then there is a backlash against the hospital. So that happens quite often in many parts of the country. So is that a deterrent to providing?
I mean, I will not say that will act as a deterrent, but then in a situation where a country like India, where even the healthcare delivery system is not properly instituted or maintained, we have to be careful in saying that, well, this system is the only one which is suitable for us. But as you rightly said, the primary PCI, all of us know, is the main thing which will save STEMI patients. Definitely must, every state should try to implement as much as possibly that particular program. There is a role for pharmacoinvasive. Our bane will be the delayed presentation where we can only request the government and the policymakers to do something about that.
So finally, I'll try to ask you something which is probably in the realm of policy, but maybe you can, if you were asked by the policy apparatus in this country about what are the things that can be done to improve primary access to STEMI care in this country, for the country as a whole. So what do you think should be our primary aim of focus?
I mean, our primary education, our primary policy should be educate our people. That is number one, because in a nation obsessed with, I will say, quote unquote, gas, every patient who has a chest discomfort has to realize that this could be a myocardial infarction and they have to reach a physician. I think that's the most important thing. All our developments in implementing the systems of care will be of waste if we don't educate our patients and tell them that this is the most important thing. I think that will come as the number one point, apart from implementing the systems of care and implementing a quality improvement program.
And one final question I have to ask you, because you see, we are a large country, very educated medical professionals, but unfortunately our research output is not up to scratch. But you have made it happen in Kerala. So what would your advice be to the rest of the country, I mean other states, in order to be able to produce this kind of data? We have lots of potential, but we've never lived up to it. So what would your advice be?
I mean, learning from whatever little things, I will say we're not a great thing, but we have done something, and that is only because of the collaborative efforts of the people, of the cardiologists and physicians in Kerala. every state possibly can emulate. If Kerala can do it, any other state can do it. What it requires is some certain leadership qualities of cardiologists who will try to collaborate with the youngsters and others who are very keen to involve in any research programs. And we don't pay them, we don't even involve them, mention them in the paper that we have released, but they are part of us. I think a collaborative effort of the cardiological group in our country will see that our research outputs improves substantially.
Thank you, Dr. Mohan, that was very good talking to you, and I hope this will provide some incentive for people in the rest of the country to emulate what you've done so that we can really produce good data to direct care.
Thank you very much. Thank you.
Thank you very much.
significant increase in the number of downloads across the world in the last 4-5 years. In 2016, there had been more than 30,000 downloads of articles from our journal. And this year, it has been 60,000, and most of these downloads happened from United States of America. That is an important aspect. And I have been serving as the editor for the last 4 years. And we have 3 associate editors, all from different parts of the country. Now we have improved our editorial board strength, and we have 15 section editors. And of note, we have section editors ranging from Dr. Samuel Ashirvadam from Mayo Clinic, Dr. Adar Vail from Europe, and 12 out of 15 of these section editors are well acclaimed senior electrophysiologists who have got significant number of publications and high impact factor across the world. So we hope we will have more visibility in the near future, more submissions, and we will also hope that we will have an impact factor in near future with Reuters, and we need help in form of contributions of important articles and also original articles, reviews, and every sort of contribution, academic contributions in near future from you all. Thank you. On behalf of Indian Heart Rhythm Society and also for the editorial team of Indian Pacing Electrophysiology Journal. Thank you.
Sound. Is it okay? Hello, is the sound level okay? And you can speak. Yeah, is my sound level okay? Okay. Hello, I am Dr. Should I start speaking? नहीं वो इशारा करेगी. Hi. Yeah, hi.
Hi, sir.
Thanks.
So both of you are going to do it in tandem. How is it going to be?
We have actually messages only.
Yeah.
So one by one we can.
Perfectly. So maybe, but let it be still informal. So maybe you introduce yourself. Then
I
you
will.
introduce
I'll
yourself.
introduce myself and I'll
then
introduce
you say,
him also.
What do you want? I mean, what your message is from to the CSI?
Right.
How is it?
To all the delegates and
Delegates. So would you say, oh, would you like to welcome all the delegates or something? You know, like it just flows.
Yes. So maybe
looks
you
good.
can start
And
you
I'll
can introduce yourself
and you also.
myself.
With me, I have Dr.
Yeah, my
Makar,
good
who is the
friend.
take. It's perfect.
Okay.
Good.
आप शुरू करें.
President-elect of the Indian Heart Rhythm Society of India, that is IHRS. And with me I have Dr. Jitendra Makkar, who is the organizing secretary of our annual conference at Jaipur. So Indian Heart Rhythm Society is the main body that is basically formed by the rhythm experts in the country, the electrophysiologists who deal with the disorders of the cardiac rhythm. And with me we have Dr. Makkar. So Dr. Makkar, would you like to welcome the delegates to your conference at Jaipur?
Yeah, sure. So good evening everyone at CSI. I am Dr. Jitendra Makkar and we are organizing 10th annual Congress of Indian Heart Rhythm Society at Jaipur on 7th to 9th of December at Hotel Lalit, and we are here to invite you all to this beautiful gathering of people who are interested in electrophysiology and device and heart failure management and who are doing good work in this field of cardiology. They all are invited. And this year IHRS will be little special because we have two combined sessions, one with the IHRS, combined session of IHRS with HRS, Heart Rhythm Society of America, and another combined symposium is with Asia Pacific HRS. So we are getting the office bearers of these societies as faculty member this time, and it will be beautiful to interact with them and take the Indian EP to next level with the interaction of Asia Pacific experts and the global experts. And secondly, also we for young EPs we are having a fellow course, so I'll invite those who are undergoing their DM, DNB degrees and they have interest in electrophysiology, they can come get registered as fellow course and they can have a nice opportunity to learn how to begin in the EP. And of course, we also have a IBHRE mock examination. IBHRE certification is a very prestigious thing for any person who is working in EP. So we are conducting a mock examination so that a fellow or a cardiologist can get a primary idea that how to go about these examinations. So, and not to miss, Jaipur is a beautiful city. It's called Pink City of India, and December is very nice weather to be there. So I'll request all of you to get registered for Indian Heart Rhythm Society meeting 2018, which is in Jaipur. So looking forward to having good times with all of you. And sir, Dr. Anil Saxena, as a president of, you have been recently elected as president of IHRS. So any message you would like to give to our CSI members who are here, how to go about membership as well as this?
Thank you, Dr. I think one of the main message is that
we have a huge number of doctors who are taking care of heart rhythm disorders, whether it is by doing EP studies and catheter ablations, or by implanting devices like pacemakers and defibrillators. And not all of them are members of Indian Heart Rhythm Society. So because we have so many activities going on, both in terms of education and conferences, that it will be worthwhile to become a member of IHRS. So I will encourage those delegates who are involved in heart rhythm problems and dealing with those problems. I will encourage them to become members of Indian Heart Rhythm Society. And I wish you all a wonderful conference, and I hope you are enjoying a wonderful conference going on, and have the best of your time. Thank you so much.
Yeah, thank you so much. Thank you so much.
It's a privilege to be here. At the outset, I'd like to thank the organizing committee of the CSI for holding such a wonderful program. The scientific sessions are absolutely stimulating. I am in my capacity as the convener of the Cardiac Rhythm Council. I've been privileged to be nominated by the CSI as a convener. So it's my brief to just outline the activities which we are planning in the next few months and what we have been doing for the past year or so. We have had ECG sessions, and the brief from the CSI to us is to increase ECG and arrhythmia awareness amongst the physicians, and I am happy to report that we have had a couple of such meetings and they have been a tremendous success. So all congratulations to CSI for thinking about this initiative. And the next meeting which we are planning is the Cardiac Rhythm Council meeting, which is scheduled to be held in February next year on 16th and 17th. We hope to have a full house. We will update regularly about what is the scientific program going to be, and wholeheartedly seek your involvement and participation in the Cardiac Rhythm Council in the months to come. Thank you. Thank you.
Yeah, do you have a program schedule? Okay, do you have this book with you?
No, I'll take my book.
Where's your book? You get that book, get that book. Yes. This is excellent. This is all that I want.
Yeah.
This is all that I want. Yeah.
Oh,
you can take this back.
So you have the program with you?
Yeah, she has a program and we have this. So we can decide. Yeah, laga do. So what I need to do is, this is a difficult thing. We have starting with Suvro Banerjee. Should all angio Suvro Banerjee, and then we go to Kajal Ganguly, then we go to SS Iyengar, then we go to Sunil Modi, then we go to Rajiv Gupta, then we go to Mohit, then we go to. Thank you, that's great. They want CSI TV to be there, and this is here. So, hi, how are you? I do recognize you, but I'm really sorry I've forgotten your name.
We met at PT in
Oh yes, oh yes, oh yes, oh yes. This also is good. How did today go? But I have no idea what we're going to do in this wrap up because you know there is nothing like new trials,
No problem,
nothing
sir.
new.
What you would say why this was still a different, so many people have attended. You had so many international speakers talking about it. We had such important 1, 2, 3, 4 sessions which are
But do we have any data on that? How many registrations do we have?
yeah, so I can give you
That's important. Yeah,
Ekta?
I think I'll ask.
Dr. Rani, there is no need to tell on everything.
ask the Bama guy.
The most important messages that was there in the hall 8 today.
Yeah, Holly today we can talk about. That's what I've written down. See, we have written down on something on what the Okay, good evening to you all. So, welcome to CSI TV. We are on wrap-up of day 1. Now, before we go to the brass tacks of day 1, let me take this opportunity to congratulate the organizers. Dr. Praful Kelka, Dr. Amit Vora, I think
the entire team, because we initially had an apprehension. You are moving away from a hotel setup scenario, a convention center of a hotel to a totally makeshift arrangement.
Absolutely.
So we thought that there will be some hiccups, but absolutely no hiccups, but a fantastic arrangement. I think all praises to Praful and his team. Air conditioning is fantastic, the seatings are good, it's an excellent environment for learning. Everything, we could not find any problem with this thing. And I think a makeshift arrangement is fantastic. They have done a wonderful job. So it's a very, very comfortable environment to learn, discuss and network.
so. A great first day and probably the best ever first day in the history of CSI conferences. So there were 4 halls. Hall A dealt with the continuing medical education. Hall 2 was interventional cardiology. Hall 3 was pediatric and electrophysiology. Hall 4 was imaging and echocardiography.
Yeah, right.
And in addition to this, I was told that they had a live CPR session going on, teaching not only our postgraduates, but also the police and the fire force.
It's a part of the social commitment of the CSI.
Good. So,
what about the registrations? You have any idea about the 2 days registrations?
yes,
Day 1?
we had fantastic registration numbers. Over 2,500 delegates registered today, and there were more than 30 foreign faculties.
And we were, usually we are worried about whether there are adequate delegates in the halls or not. What is your feel on this thing?
The halls were full. In fact, there were people standing in Hall A and Hall B.
And the Hall B, I think I attended some of the sessions in the Hall B, it was full.
That's good.
It was full and active discussions going on.
So we are going to give you a snapshot now of what actually happened in Hall A. And I think the day began in Hall A with what they call as the new kids on the block. They discussed about newer drugs, newer therapies, and then subsequently when the controversies in cardiology. I think one of the controversies that I liked was the controversy when Dr. Survo Banerjee was asked this question: should angios be done in all patients with an acute myocardial infarction presenting after 3 days? And I think in his discussion, the OAT trial prevailed. And he reminded that the ESC guidelines gave a class 3 recommendation in asymptomatic patients. And he quoted the CSI guidelines for acute myocardial infarction presenting after 72 hours. And it says that if there is symptoms like hypotension or arrhythmia, then they should be taken up to the intervention lab. And if it's asymptomatic, he stated that you must have some test for ischemia or viability before going into the lab.
It is not something like a blanket statement that after 72 hours you need not have to do anything in a completely occluded vessel. It depends upon the circumstances.
And then interestingly, subsequently, Dr. Wander discussed, vaccinations in cardiology.
Right.
And ACC gives a class 1 recommendation for vaccination in cardiovascular patients, while the ESC apparently gives a class 2B recommendation. So what are your viewpoints on this?
Because I have heard the heart failure talk, because there was an entire session on heart failure. There, even vaccination is a class 1 indication. The Haemophilus influenza vaccine as well as the pneumococcal vaccine, it's a class 1 indication now for heart failure patients. But for other cardiovascular diseases, and for that matter, for diabetes is also it's an indication now. So vaccination is coming up.
To quote him, he said, as physicians, it's our duty to give the flu shot and the pneumococcal vaccine, especially in diabetics and heart failure patients. What was your take on the heart failure session that took place in the afternoon?
The heart failure session was fantastic because they moved from the basics of the heart failure treatment, the guideline directed management, up to the use of LVAD or mechanical cardiac support as either a destination therapy or as a bridge to transplant or a bridge to decision. Many things. For example, the most important thing I think they have discussed is one regarding the iron deficiency, because that is one area where it is neglected. 30 to 50% of the patients will have iron deficiency, and iron deficiency is not equated with anemia. There are 30% of the patients who may have iron deficiency without anemia, and it's our duty to look for iron deficiency, looking at the transfer in saturation, whether it is less than 20%, the storage iron by looking at the ferritin, whether it is less than 100, and treat them with not oral iron, intravenous iron. So an intravenous iron improves the quality of life, and that was the message that was given by, I think Dr. U. Samal was discussing on it.
Dr. Jayaprakash spoke on CRTs and ICDs.
Yes,
what was your take on that?
The most important message I could gather is if a patient with LV dysfunction, LV ejection fraction less than 35%, if he has an indication for pacemaker, because all the other things it is standard, if he has an indication for a pacemaker, it may not be a pacemaker, rather it must be a CRT. So if there is an indication for pacemaker in an LV ejection fraction less than 35%, preferably it is CRT. Otherwise, CRT indications are standard and it is a guideline recommended management. And those patients who are going for a CRT, I think there is a significant improvement in the ejection fraction, and you can come down on drugs also after CRT when the ejection fraction improves.
There was another good discussion by Dr. Yadav on LVADs. What did you take about that?
LVADs, because he talked of the mechanical cardiac support devices starting from the IABP, and as per him the data is not supportive of IABP in majority of situations, then the ECMO and then the other mechanical cardiac devices. ECMO has got a problem because it's a short-term mechanical support device. Unless there is a reversible factor, ECMO is not going to help, and at the same time ECMO has a lot of complication rate and it increases the LV resistance also, the resistance to LV pumping. When we come to the newer mechanical devices, and of course ECMO may require a venting, either a venting by the surgical venting of the ECMO, the LV, or sometimes a combination with an impeller and the ECMO. And those patients with chronic heart failure, now reached an end-stage heart failure, on a transplant list, we may have to go for a mechanical cardiac device. In the current, the best seems to be, with the data he presented, the best one seems to be the totally magnetic levitated, the HeartMate 3.
What else was there in heart failure among the talks?
Then there is a guideline directed management, the use of an ARNI.
I think ARNI took a lot of space during the heart failure talks, and subsequently I think they moved to hypertension, where I think Dr. Venugopal spoke on.
So it was an important topic, and before that Dr. Venkatram, he was talking on whether there is a difference in the guidelines, the European guidelines and the American guidelines. Basically he was giving a message that though there is a difference in the definition, the Europeans still use the 140/90, the Americans use the 130/80, but the goal of therapy is basically you go more aggressively in majority of the situations if tolerated less than 130/80 millimeters of mercury.
I think that's a very good message. That I was there and I heard that Dr. Venkatraman said, whatever the Americans, whatever the Europeans or whatever the Indians think, the target remains the same, less than 130/80.
And Dr. Venugopal was discussing which is the first antihypertensive agent. There are first line antihypertensive agent, which agent will you prefer? But his message, he had gone through the data of all the antihypertensive agents in majority of the hypertensive situation, and basically he stressed upon one thing. Its most important thing is not the drug, the control of blood pressure. So it could be any of the first line agents. It could be an ACE inhibitor, it could be an ARB, it could be a calcium channel blocker, it could be a diuretic. And it depends upon the comorbid situations and other features. You may decide on which drug to start first, and mostly hypertension needs more than 2 drugs. So there is no much sense in saying which is the first drug to be started. So the control of blood pressure, and if the target or the goal of therapy is if the blood pressure is at 20 millimeter above the goal blood pressure you need, then it is better to start a combination therapy.
Of course, let us not forget that in the morning there was a huge discussion on lipids. And I will tell you some of the highlights of that lipid. I think Dr. Kajal Ganguly spoke about the guidelines.
The
And
new
he's-
guidelines, isn't it? The
Well,
new
he said that the guidelines are very confusing, but he brought out 3 points, and I'll read out the 3 points that he said. One, he said that the targets are back, that is an LDL less than 70.
The numbers are back again. Now there is nothing called, you just blindly treat the lipids. And now the numbers and the targets are back. The
Second
70,
point,
50
he
and
said
all back.
the PCSK9 are the new kids on the block, and he said something important, and that is all diabetic patients must have statins. And previously it was only above the age of 40.
It was
very
previous
confused on
guideline
that.
is 40 to 75. Then you start on a moderate intensity statin therapy, and depends upon the further risk profile, you may go for an aggressive treatment. But now everybody is of the same opinion that a diabetic needs, irrespective of his lipid level, irrespective of the age, he may need a lipid lowering therapy.
Dr. Iyengar spoke on how low should the LDL be, and his first slide said that you require an LDL of only 27 to survive. And he said the lower the better, especially now with the PCSK9, and he said there's no harm in lowering the LDL.
Because the PCSK9, they have gone down up to 20 milligram per deciliter, and in certain cases even up to 10 milligram per deciliter in the Fourier trial. But it's a short-term follow-up of 3 years.
And Dr. Sunil Modi spoke on the choice of statins, and it's very interesting because he said in more than 50% of cases, it's a personal choice. You really do not have advantages of one statin or another.
It's not an evidence-based choice, rather it's a clinician's choice.
Now, there were some discussions on the cardiovascular risk scores. There was Dr. Rajiv Gupta, and I think he brought out an important point. He said that the Western scores, the Interheart or the Framingham, is not applicable to Indians. It may be only so in about 50%. And he said that they are developing a multiple gene risk score, which may be more applicable to Indians. Then regarding the cardiovascular risk factors, Dr. Mohit Gupta gave a good lecture, and he said that in about 25 to 30% of patients, there are no risk factors, and they were emerging risk factors. What he called them was risk enhancers, like the CRP, interleukins, and they all needed to be tackled.
And now the current lipid guidelines also, now they are using the terminology, it is the risk enhancers. It's the risk enhancers. And there was something about hypertension and stroke, whether should you control the blood pressure acutely in acute stroke. So though it was not related to that particular thing, but Dr. Yashpal Sharma, one thing that caught our attention was it's importance of correction of iron deficiency anemia to prevent stroke. That was a new thing which I have never heard that thing. Correction of iron deficiency, especially in countries like ours, where iron deficiency anemia is widely prevalent in those patients with risk factors for stroke. That should also be controlled to prevent a stroke, which is a devastating illness.
And I think in that session, Dr. Anjan Lal Datta also brought out a very important point, screening for secondary hypertension.
Right.
And he said, I think to quote him, he said, resistant hypertension is more resistance from the doctors.
Yeah, 5 to 10.
Find a cause for the
5 to
hypertension.
10% of the patients have resistant hypertension, and if you enumerate the causes, the most important thing is the renovascular, the renal parenchymal, and then don't forget about the primary hyperaldosteronism, which is a little more prevalent than what we think. The 5 to 10% of the resistant, or 20% of resistant hypertension may have some variant of primary hyperaldosteronism, which is treatable and curable.
So,
and obstructive sleep apnea, we should not forget, when you see a resistant hypertension, always
that was also brought out by Dr. Anjan Lal Datta.
Ask for an obstructive sleep apnea and go for a sleep study, and his blood pressure may improve with the correction of the sleep apnea.
So, ladies and gentlemen, we have missed out on a lot of other
One more
speakers.
thing I would like to tell is the need for ABPM in resistant hypertension, which was brought about by Dr. H.K. Chopra. He was stressing on the resistant hypertension, where you have to use a ABPM to know whether it is really resistant or not, and how the management helps to control the blood pressure. So rather than a clinic blood pressure, ABPM should be stressed, and he is telling that in resistant hypertension, you have to use an ABPM to diagnose resistant hypertension and also to follow up management of the hypertension.
So overall, fulfilling day one at the CSI Mumbai. We have missed out on a lot of other lectures that have taken place, but this is the shortest wrap-up that we could provide you. Thank you. Okay. This is Dr. Jabir, and I am Dr. Ronnie Matthew.